Good afternoon, my friends. I'll be talking about really important topic that we used to face every day in our daily practice. That is how to deal with the cases of prostate cancer with a rising PSA or detectable PSA after definitive treatment, whether surgery or radiotherapy, when we have to start such treatment. First, we'll have to really to define what do we mean by detectable or rising PSA and how we define it after surgery or radiotherapy, and also what we mean by the biochemical failure or relapse, and also what would be the best for those patients to go early in treatment as an adjuvant therapy or as a salvage therapy. And also, whenever we select any option, is it really good for patients? Any impact on the outcome for the patients? Now, for clinically localized prostate cancer, whether low, intermediate, or high risk prostate cancer, as you know, the surgery or that is the radical prostatectomy or radiotherapy are considered to be curative options for these cases, but still we face recurrence rate or biochemical failure is about 20 up to 25%. So detectable BSA level after radical prostatectomy or an increased BSA level following radiotherapy are considered the biochemical recurrence or BSA failure. So the biochemical recurrence can indicate really a disease progression years before the clinical signs and symptoms develop. So the question when really we have to consider treating those patients, keeping in mind the quality of life and the side effects of the treatment, the performance status of the patient, many factors to be considered before considering what the treatment and when to consider this treatment. So specific criteria for determining the biochemical relapse in prostate cancer differ according to the type of treatment, whether it is radio or surgery. Now, after prostatectomy, the BSA usually becomes undetectable within 6 weeks. And we will discuss what does it mean, the undetectable, but because what we practice now, not like what we practiced 10 to 15 years before, definition of the undetectable BSA. While detectable BSA following the prostatectomy most likely implies residual or recurrent disease. So even if it is within the few weeks or months after surgery and still there is a PSA is detectable, say 0.5 or 1 or maybe more, so it means that we are dealing with a persistent disease or residual disease there rather than recurrence. But if it happened after a few years from the surgery, probably there is a recurrent disease. We have to differentiate between both the persistent disease after surgery or a recurrent disease, because probably the treatment will be different. Now, before we used in many actually studies that point 2 is the cut point for the definition of the biochemical failure after surgery. And actually, because most of the machines did not detect before that, now below that. Now we have actually so sensitive machines where even less than 0.006 or 8 now considered to be the undetectable. That's why it's important not to wait up to 0.2 to say this patient is having a persistent or recurrent after surgery. It is anything more than 0.006 or 8. This is residual or gradually or detectable the PSA, which is really important to consider. So now when we are talking about post radical prostatectomy, so the PSA undetectable means it's less or 0.006 or some machines 8, but it's not 0.2 because probably will take time between 0.006 to reach 0.2. And so undetectable, it is above this level. Probably most now of the clinical trials and the practice to consider action to be done if the PSA is about 0.1. That depends upon, as I mentioned, the patient's age, the PSA kinetics of the PSA and the duration between surgery till it reaches 0.1. Most of the many factors to be considered for this. While what about the post-radiotherapy? What is the biochemical failure? It was defined by Astro and Phoenix definition. That is an increase in the PSA 2 plus nadir. So if you treat radiotherapy for a patient with prostate cancer, and then the nadir with or without hormone therapy, and then the nadir will become, say, 1 or 2. So to define this is biochemical failure, it is 2 plus the whatever number of nadir, which is usually the nadir can be achieved after 6 to 9 months after radiotherapy. But still, even in this, you have really to read it very well, the Phoenix. You need not to wait for patients after radiotherapy to reach 2 plus the nadir. Simply because you have to see the kinetics of the BSA, the duration of the doubling time of the BSA, less or more than 10 months, so many factors before reaching 2 plus nadir. And this was clearly mentioned in the NCC guideline, the latest report, 2021 February, that a recurrence evaluation should be considered when the PSA has been confirmed to be increasing after radiation, even if the increase above nadir is not yet 2, especially in candidates for salvage local therapy who are young and healthy. So probably you need not to wait to have 2 plus nadir to react in healthy and young patients. So what scenarios, let's come to the first part, how we deal with biochemical failures or persistent disease after surgery, after the radical prostatectomy. So the first clinical scenario is that patient, 62-year male patient with intermediate risk group, BSA 7, L12, glycemic score 70, to be radical prostatectomy was done. Post-op pathology report came to be negative margin, no extracapsular extension, no seminal vesicle involvement, undetectable BSA. So most of us, all of us actually, will agree that this patient will go for follow-up only. The other scenario, that 55-year male patient, for example, with prostate cancer, Gleason was 7, 4 plus 3, BSA 18, T2C, underwent radical prostatectomy. The pathology report came with high risk factors, the 3 high risk factors that usually, or the 4 we are talking about: T3A extracapsular or T3B seminal vesicle involvement or positive margins. So what to do? In the first patient, at the left side, the 4 weeks or 1 or 3 months BSA is undetectable. Should we really advise for adjuvant therapy in the undetectable BSA? Scenario number 2, that patients, the same 64-year patients with the high risk, underwent radical prostatectomy, and the pathology report came to be positive margin, extracapsular involvement, and the BSA at 4 weeks, 1 month, 2 or 3 months. This is just an example, and you can see that there is a slight increase in the BSA, but it's still the last one, 0.04. In this case, with the high risk factors, should this patient go immediately? And when we say that the adjuvant therapy, it means after surgery within 6 months. Anything above 6 months, we call it as salvage. So should we treat this patient within 6 months of therapy, or we can wait, like the scenario number 1? Now, scenario number 3, that again, 69 male patients with glycine 8, BSA 23. Post-op report came to be at T3B, seminal vesicle involvement, positive margin. And the BSA is slightly increasing rapidly after surgery and reaches 1. If you do a PSMA or MRI, you'll see a residual, small residual at the tumor bed. Should this patient be treated as scenario number 1 or number 2, or it's a different story? And I tell you from now that this is a totally different story for the scenario number 3. You have to treat after you having within 6 months the patient is continent for urine. You have to start radiotherapy locally and a short course, 6 months of hormone therapy. But the question for scenario 1 or 2, and this is the question: can you wait later on to consider adjuvant therapy in terms of local radiotherapy, if it is still it's local, no distant metastasis, and short course 6 months hormone therapy, or you may delay after the 6 months as a salvage? And this is the question. So, and these are actually like the scenarios that I just mentioned. And these are the high risk factors. Now, many studies already try to answer this question that all patients with the high risk group factors after the surgery should go for adjuvant therapy. And these study, the SWAG, ARTC, and RO studies, all randomized one, they showed that we can achieve a better long-term biochemical control, but without any increase or advantage in overall survival and metastasis-free survival benefits. And also these studies taught us that 30% of patients allocated to observation did not have any disease relapse. This means that some patients really that you don't treat, right? There is no need at all, even with the high risk, for any adjuvant therapy because simply they will not have any progression of the disease. And if you treat them, probably you are over-treating them and adding side effects and affecting the quality of life. So the question that should all patients with high risk factors after prostatectomy immediately within 6 months, that is the adjuvant therapy, should be considered, or we can save some patients to consider treatment if necessary later on. Two new studies just published in 2020 answered this question. The French study and the Radicals RT, which is UK, Ireland, Denmark, and Canada. The first one, I think 45 hospitals in France took part in this study just to answer this question. Can we defer adjuvant therapy later on, or all patients with high risk factors after surgery should be given the radiotherapy and adjuvant therapy, that's 6 months hormone therapy? Now, and this is the publication Lancet Oncology 2020, the adjuvant therapy versus early salvage radiotherapy plus short-term ADT, 6 months hormone therapy in localized prostate cancer after radical prostatectomy. Is a randomized phase 3 trial. And the study designed all patients above 18, performance 0 to 1, localized disease with or without lymph node dissection, and those patients who had T3A, T3B, or T4A bladder neck invasion, and also the patient that reaches 0.1 or less after, and that has to be confirmed after 4 weeks of the PSA. So it's around 212 in each arm. And you can see here it's well balanced between the two arms, arm only observation and keep it like a salvage, and one adjuvant therapy immediately within 6 months. Adjuvant means we're talking about 6 months till patients is having a continent of or control his urine. And the result is that there was no advantage in the event-free survival and overall survival for the two groups, whether you consider radio within 6 months or you delay the treatment later on. And of course, the side effects a little bit was more for the adjuvant therapy because still probably the area is unhealed, and considering radio for all patients probably will have some more side effects, especially talking about the urethra and necrosis and incontinence. So their conclusion was, although our analysis lacked statistical power, we found no benefit for event-free survival in patients assigned to adjuvant radiotherapy compared with patients assigned to salvage radiotherapy. Adjuvant radiotherapy increased the risk of GU and erectile dysfunction. A policy of early salvage radiotherapy could spare men from over-treatment with radiotherapy and the associated adverse event. So that really supports the practice that just to delay radiotherapy later on, because that will not have any bad impact on the overall survival or disease-free survival. The other important one with a very good really number of patients, about 700 patients each arm, which is the UK, Ireland, Denmark, and Canada study, that the timing of radiotherapy, which was also in Lancet 2020, the timing of radiotherapy after radical prostatectomy, that is the radicals RT randomized control phase 3 trial. Again, those patients were with high risk were just stratified into adjuvant radio or observation therapy. And again, it's the cut point was like zero point 0.1 with the positive margins or the Gleason score 7 to 10 or pathological T3. And radiotherapy was considered either hypofractionation, 52.5 and 20 fraction, or 66 and 33. And we know that for adjuvant therapy to the prostate bed, you need really to consider 66 to 70 degree. And in my hospital, our practice to consider 70 degree and 35 fraction. Although the hypofractionation can be used as well. So, and this study was done between 2007 until 2016. And as I mentioned, very good number of patients, about 700 patients in each arm. And again, well balanced, be it salvage radiotherapy or the adjuvant radiotherapy within 6 months were considered. And again, the same results like the French one, no benefit in overall survival and no benefit in the disease-free survival. Or biochemical control, it was the same. But of course, the side effects were more in patients who received immediate within 6 months or the adjuvant radiotherapy, mainly the cystitis, hematuria, and urethral structure. So, and they advised that to consider salvage treatment for BSA, biochemical progression, should be the current standard of care after radical prostatectomy for patients with the high risk factors. Always keep in mind the quality of life for those patients, the age of the disease, the quality of life, the comorbidities all together. And this is one of the quality of life, slide in the NCCN guidelines, how to calculate it and how to consult your patient. So probably what fits one patient doesn't fit the other patient as well. Always keep in mind the age, comorbidities, quality of life, side effects, sexual activities in mind before deciding which treatment to go and when to treat. So this is also also in the NCCN that after surgery you can consider radio or observation, and if radio plus minus 6 months of hormonal therapy. Now coming for the other part of the talk, that after radiotherapy, not after surgery, after radiotherapy, when patients will have a biochemical failure, what would be the best treatment? Now this is an example. You may have a patient, 72-year-old male patient, prostate cancer, with the intermediate risk group, and this patient underwent either a 1620 hypofractionation using VMAT, like what we do at King Hussein Cancer Center, or the conventional 178 and 39 using IMRT or VMAT. And then since patients is intermediate with 2 factors, so 6 months hormonotherapy was considered for this patient. The nadir BSA was 0.002, and then you follow this patient up, and with time, with years, you'll see that there is increase, as you can see here in the BSA. After 4 years from radiotherapy, you'll start every 3 months. There is a gradual. Now, it is really important in those cases to know whether you are dealing with a disease confined to the prostate, or we are dealing with the disease spread to the pelvic lymph nodes or to the bone or other viscera. And now, usually we do CT scan, chest, abdomen, pelvis, and MRI of the pelvis, and CT chest and abdomen, and bone scan, just to find out whether we are dealing with the biochemical recurrence, increased PSA alone without any radiological evidence of disease, or we are dealing with metastatic disease, which is another issue that I'll not be touching. Now, most of the cases, when you do these studies, and now we replace this with the PSMA, which is really very sensitive, and it's in most cancer centers now, available to do a PSMA, rather you can skip the CT chest abdomen bone scan. PSMA, maybe sometimes you may ask for MRI pelvis, but probably PSMA is very sensitive to show you the where the recurrence is. Now, factors to be considered for these patients where the BSA is started rising after few years from treatment. What was the primary presentation prostate cancer? Initial BSA, the T stage, glycerin score, you should keep it in mind. And then the now about the increase of the BSA, what's the interval of failure? The BSA kinetics is really important. Doubling time is important, less or more than 10 months. Patient features, life expectancy, sexual status and concerns, and the urinary also status. All these factors to be kept in mind while dealing what is the best for this patient. I should say that probably dealing with such patients is not straightforward. There is no really one only recommendation of treatment to consider. So if we are doing the BSMA or the other radiological, and you find that there is only increase the uptake inside the prostate, of your take a biopsy and there is only by recurrence in the prostate after radiotherapy. So the mostly what we used to do, our most practice to consider intermittent hormone therapy. And actually this is good and it can lower down the BSA, but you should keep in mind that this is really a palliative approach, it's not a radical approach, because maybe that you need really a local therapy to try to control the tumor inside the prostate rather than just only intermittent hormone therapy. 1 year stop, probably 2 3 years will be okay, and then the PSA will increase again. You may reinduce hormone therapy, but try to have some local therapy, which is sometimes really difficult, because the local salvage is like radical prostatectomy salvage. You can do it, but it's still the as I'll show you now, the incontinence is very high in those patients. And also the HIFU have been tried, the cryosurgery, as all local modalities have been tried, and prostate irradiation recently with the SPRT also has been tried, but we do not have much data about it. So even the brachytherapy also, it's one option that can be considered as a local therapy. Now, if you consider salvage radical prostatectomy for those patients after failure of radiotherapy, the 5 years disease-free survival reaching 50 to 60%, but the incontinence, as you can see here, is high, it's about 50, 60%, and that also might affect the quality of life of those patients. And this has to be discussed with the patient and to see which patient is really good to be considered. Brachytherapy also, again, have been used, or 5 years. Again, free survival is about 70 to 80%, with still with some side effects. And here, if you can see the NCCN guidelines, the latest, the options are there. Depending upon life expectancy more than 10 years, then you may consider observation only, or surgery, or brachytherapy, cryo, or HIFU. If the life expectancy is than 10 years, either the observation or the intermittent hormone therapy. 1 year stop, see how things go, and then you may consider later on the hormone therapy for another 1 year. So to conclude, post-surgery, patients with high-risk factors, adjuvant therapy, that is radio and short course of hormone therapy, can be safely delayed with no negative impact on patients in terms of overall survival and disease-free survival in some patients. While if you have a residual and persistent disease after surgery, within 2 3 months, still BS is very high or high, and then the adjuvant treatment with radiotherapy to the tumor bed and short course hormone therapy is really needed. Now, post-radiotherapy, the biochemical recurrence, it's not easy situation. Now, currently can be managed by intermittent hormone therapy, salvage, surgery, brachy, HIFU, as mentioned, or systemic therapy like apalutamide. But in all these cases, as always we say, to approach these patients, it is through the multidisciplinary clinic to discuss from all aspects the patient's condition and then to decide. Thank you so much for giving me this chance, and I wish your conference all the best, inshallah. Thank you.